The ESC this year was rich with guidelines. The ESC 2024 AFib guidelines have some very substantial changes. So I'll try to run through that. This is, Dr. Abdullah taught me how to do this, a WhatsApp. You can have a QR code, scan it. I'll send you the slides if you want. Okay. So something new about non-invasive methods to screen for AFib, screening in the outpatient setting. That means you can use some of these tools. Pulse palpation, of course, in the clinic, you have to tell them to use a pulse oximetry. And also you have these portable monitors that are now available on every iPhone and Samsung and every smartwatch. So they are telling us that you need that. Why? To catch AFib ad hoc. Any rhythm check with any ECG is an opportunity to prevent a stroke. So that's really a way to use the over-the-counter technology to help patients. And then, of course, you can actually use that to screen in large populations if you have the database. So that's like the Apple Watch study. So that's one very important point. The second one, which I think is extremely constructive, is this thing called CARE. So CARE is not just about anticoagulation. Let's just take anticoagulation as only one of the 4 boxes. Managing comorbidities is absolutely critical, including lifestyle and internal medicine, weight loss, SGLT2, GLP-1. There's a lot of stuff here in the guideline that reflects the whole cardiometabolic approach to medicine. So this is too complex to go through in a short lecture, but it is telling us that you can prevent the onset of AFib by careful management of hypertension, obesity, heart failure, sleep apnea, and also alcohol avoidance. So there's a whole section here on managing comorbidities. There's a section here on diabetes and glycemic control. Particularly, they talk about obesity. 10% obesity loss has a significant impact on hypertension as well as AFib, and also management and prevention of sleep apnea. So this is very important for every patient with AFib. It's no longer just anticoagulation. This is the cardio-kidney metabolic, the circular approach around AFib. So the same risk factors for cardiovascular disease, not just MI, are overlapping. So remember, age, gender, genetic factors, race, you can't prevent, but you can treat diabetes, high blood pressure, you can treat hyperlipidemia. Obesity is now a target for cardiovascular professionals. We have to get into obesity very efficiently. Smoking cessation, physical activity. What do you get out of this? You have reduction of ASCVD, MI, stroke, and PAD, heart failure, and atrial fibrillation. It is strictly a very important concept to think about. So this is the CKM. I think you've seen this last year in the American Heart Association. It starts from here. This is the obesity with risk factors and can be used to prevent subclinical disease and also AFib and stroke. It's in this diagram. So it's very important for us to remember that starting early and having multiple risk factor modifications, including targeting obesity, has a big impact on the onset of AFib and stroke. Now, BMI is a little tricky. As we get into this as cardiologists, remember, BMI is not the only solution. It doesn't tell the whole story. This is a patient who has a lot of visceral fat but lower muscle bulk. This is an athlete who has a lot of muscle bulk and no visceral fat. This one has a higher BMI. Which one of these two is going to have a cardiovascular event or high risk? It's the one on this side. So BMI doesn't tell the whole story. Visceral fat, waist circumference are now emerging as more powerful tools to prevent and detect this disease. So we're going back in history now, and this is how you prevent cardiovascular disease. This is a big fat tree. It's called the baobab tree. It's actually native to Oman, where I just was at. And if you think about it, if you cut the problem at the root, you avoid having to deal with all the branches. AFib, heart failure, right? CKD, CAD, all of this. We've been dealing with this in silos, the electrophysiologist here, the cardiologist here. What if we cut the root of the tree at its origin? It appears to be that obesity is the central factor for all of these inflammatory metabolic disorders. Start from the base, don't waste time cutting the branches. And the thing is, if you start at the beginning with risk factors and hypertension and obesity, you can prevent atherosclerosis, you can prevent AFib, you can prevent CAD, you can prevent the inexorable progression to renal and cardiac target organ damage. The earlier you start, the more effective we can be. This, of course, is very complicated, but these are the molecular mechanisms that lead to inflammation, systemic inflammation and insulin resistance, contributing to cardiovascular disease and obesity, particularly AFib, heart failure, and CKD. So this is what's now known. This is the science. It's well known that obesity increases cardiovascular death, coronary events, all risk factors, causes hypertension and obstructive sleep apnea and microalbuminuria, novel obesity causing AFib, and obesity causing HFpEF. In the 2024 other guidelines, the CAD guidelines, very clear that you should be using a GLP-1 receptor agonist to reduce the risk of cardiovascular mortality, MI, and stroke in atherosclerotic patients without diabetes. And therefore, this is a key component of our treatment. Now, what about AFib and obesity? There's an increased prevalence of heart failure, more CHD, more hypertension, there's LV remodeling, there's atrial remodeling, there's neurohormonal activation, epicardial fat is a big problem, also autonomic dysfunction and obstructive sleep apnea. All of these are causes of AFib in the same patient that you see for heart failure and coronary heart disease. It's extremely common. This is a very nice paper about the model of epicardial adipose fat, how it prolongs the action potential, conduction slowing, intermyocyte disruption in the atrium. Other effects that cause atrial fibrillation, including hemodynamic, LV remodeling, stiffness, insulin resistance and neurohormonal activation, sympathetic overdrive, and fibrosis, where in the atrium as well as the ventricle. There's a direct link between all of this and obesity. This is a beautiful study where they looked at epicardial adipose fat. I don't know if you can see this, but they actually measured it quantitatively in the green and red bars. And this is extremely important to recognize. Increased epicardial adipose fat contributes to a significant increase of heart failure and preserved ejection fraction and atrial fibrillation. Look at this. This is going to be coming very soon to every MRI that you're doing. So the other, back to the guidelines. I'm sorry we had to go out a little bit and come back again. So the guidelines. Chad's VASC score has been adapted. There is no more S. No more S. Why? Because there is actually no difference in the score between male and female to reduce confusion. So it's still chronic heart failure, hypertension 1, 75 or above 2, diabetes is 1, prior to stroke TIA or embolism 2, and vascular disease. Age, 1 point for 65 and 74, 2 points 75 and above. No S. Right? It's not to mean that women don't have extra risk. They do, but it's a risk modifier, not a calculatable number. That's one. So, how about this? A Chad's VASC score of 1 should be considered an indicator of increased risk, and don't withhold of the score of 1 if the patient has other risk factors or comorbidities. Think about this point. It's not saying don't give it. It becomes an individual treatment choice. A Chad's VASC score, there's no S again, of 2 or more, anticoagulation, preferably, of course, no F. So, common errors in practice are addressed here as 3A and 3B. Do not. Short duration of AFib does not reduce stroke risk. Short duration of AFib, even 5 minutes on a pacemaker, please anticoagulate the patient. Do not make this mistake. Secondly, don't use aspirin or clopidogrel in these patients with short duration of AFib. It does not reduce the stroke risk, only increases the risk of bleeding. This is a very important teaching point. It's now class 3 indication. Next, inappropriate dose reduction. Again, the doses are very clearly spelled out. When you reduce apixaban from 5 twice a day to 2.5 twice a day, 2 out of 3, not 1 out of 3, okay? Old only, not enough. Weight less than 60, not enough. Creatinine more than 133, not enough. 2 out of 3. Why? Inappropriate dose reduction increases stroke risk and does not actually reduce the risk of bleeding. That's a fact. It's stated very clearly in the guideline. So, don't do it. So, with the other medications, again, edoxaban, rivaroxaban, do not dose reduce unless they have the correct criteria needed. Acute coronary syndrome. Again, appropriate dose reduction in ACS, PCI when combining with aspirin and clopidogrel, 15 milligrams in combination, dabigatran 110 compared to 150, and then go back to the normal dose once the aspirin is out of the window. Risk of thrombosis and bleeding is a risk-benefit ratio. Again, appropriate dose reduction. In these cases, stop the aspirin within 1 week. Now, what about acute coronary syndrome? Antiplatelet therapy beyond 12 months is not recommended in stable patients with chronic coronary and vascular disease with oral anticoagulation, lack of efficacy, avoid major bleeding. So at the end of the year, stay on your DOAC, forget everything else. Very clear, okay? Resume standard dose DOAC 12 months after ACS PCI. Stop ticagrelor or clopidogrel after 12 months. Simple rules for a lot of patients, very important. And that's it. Again, this is the QR code. If you want to send me a message, I'll send you the slides. Thank you.